Well, I've been getting some chest pain, but when I get out there, I just get this chest pain. My father had a heart
I
attack.
guarantee that you will get assessed in taking a chest pain history during medical school or your clinical training. So it's definitely not a history that you can shy away from. The underlying cause in many cases is potentially lethal, especially when it occurs suddenly. In this video, I'll guide you through a real-time chest pain history, sharing insights, tips, and key questions to ask to elicit crucial information from the patient. Follow along and see if you can get the diagnosis correct. Stand clear. Good morning, my name's Dr. Ali. I'm one of the doctors here. Can I please start off by confirming your full name and date of birth, please?
It's Andrew Appleyard, and 24th of August 1965.
Okay, nice to meet you, Andrew. Can I call you Andrew?
Andy.
Andy, okay. And how may I help you today?
Well, I've been getting some chest pain when I do the gardening. I mean, I love gardening, but when I get out there, I just get this chest pain.
Can I just confirm, are you in pain at the moment?
Oh, no.
Okay,
no,
that's great. So tell me a little bit more about the pain. Where is it?
It's in my chest, but it sometimes goes up into my neck.
Okay. When did it last occur?
I would say a week ago.
A week
last
ago.
year.
Okay. And how long does it last for when you're in pain?
Maybe a couple of minutes.
A couple of minutes.
That's all, 1 or 2 minutes.
What brings it on?
Well, as I say, gardening, if I do something heavy like lifting or digging.
And has this pain ever been brought on when you're not doing anything strenuous, when you've been at rest?
No.
Okay. And can you tell me a little bit more about the character of the pain?
Well, it's kind of a dull pain, I would say, and it feels like a pressure on my chest.
And you said it radiates to the neck. Which side of the neck?
Well, the left side, I'd say.
Yeah. Okay. Does it go to the jaw at all?
No.
And what about the left arm?
No, it's just the up into the neck there.
Does it ever radiate to the back?
No.
Okay, no tearing pain in the back?
No.
And when you do have this pain, do you feel like you're about to faint?
No.
Okay. Do you have any clamminess?
No.
Any sweating?
No.
You feel like your heart is racing?
No.
Any nausea?
No.
No, you've not vomited at all with the pain?
No.
Okay, any breathlessness with the pain?
No.
And what relieves the pain?
Or just rest. If I sit down, that will relieve it.
And you said that strenuous exercise exacerbates it?
Yeah.
Okay. And how severe would you say the pain is? Well, a scale of 1 to 10, 10 being the most severe.
Let's see. I'd say 7 out of 10.
7. Okay. So it's quite severe.
Yes.
Yeah. And how are you sleeping at night?
Sleeping's okay. Yeah.
Do you ever wake up breathless?
No.
Do you need more pillows to sleep on?
No, just have just one pillow.
Okay. And any ankle swelling at all?
No.
Do you feel that the pain is relieved when you sit forward?
No.
What about when you lie flat? Does the pain get worse when you lie flat?
No, it makes no difference.
Okay. What about after a heavy meal? Does the pain get worse after a heavy meal?
No, it doesn't make any difference.
In terms of your past medical history, have you ever had this chest pain in the past?
No.
Just a routine question, but have you ever had a stroke in the past or a mini stroke?
No.
Do you suffer from poor circulation in the feet?
No.
Okay, so when you're walking, do you ever get cramps in your feet at all?
No.
And what about diabetes? Has anyone ever said you have diabetes?
No.
Do you suffer from high blood pressure?
Yep. High blood pressure and cholesterol.
And cholesterol. Okay, high blood pressure and cholesterol. So just to summarize, you've had this dull chest pain in the middle of your chest, and it sort of radiates to the left side of your neck. It last occurred 7 days ago. It only lasts 1 to 2 minutes. You don't have any other symptoms when you've got the pain. You're otherwise well in yourself, apart from having high blood pressure, for which you take antihypertensives, and you have high cholesterol.
I do suffer from anxiety. I'd get very anxious about things.
Oh, okay.
But one of your colleagues put me on some medication, and that's really helped.
Okay, that's good to hear. So how long have you suffered with anxiety for?
A couple of years.
A couple of years. Do you feel anxious with this chest pain?
No, not anxious. I mean, worry because you don't know what it is. But he also put me on some talking therapy,
Okay.
which for the anxiety, and
Yeah.
I think that helped too.
Okay, yeah. So when you do have this chest pain, are you hyperventilating, breathing faster? Do you have any tingling in your fingers at all?
No, it's just the pain
Just
there.
the pain.
Yeah.
Okay. So what sort of medicines are you on then?
I've written it down. Do you mind if I just
Sure,
refer to it?
Yeah.
Well, for the anxiety, I take sertraline.
Yeah. Perfect.
For the high blood pressure, it's amlodipine.
Mhm.
And cholesterol is atorvastatin.
Okay, great. And you take all of them regularly?
Oh, yeah.
Okay. Any allergies at all?
No.
Anybody in your family suffer from heart disease or, God forbid, a stroke? Class.
My father had a heart attack and he was treated at the London Chest. And they were brilliant, you know, they're really good. Yeah, they really helped him and they were just very good.
And how old was your father when he had a heart attack?
I think he was 77.
77. Who's at home with you?
And my wife, Mariella.
And is she well? Yeah.
Oh, yeah, touch wood.
Okay,
Yeah.
good. And do you smoke at all?
No, but I did used to. I used to smoke quite a bit, but then when we got engaged, which was 25 years ago, my wife insisted that I stop, so I did.
That's very nice. That's great. Congratulations. It's hard to stop smoking, and you
It was at the
managed
time,
it.
but that was in the past.
And you've managed it. Well done.
Yeah.
So well done. Do you drink?
I like a glass of wine, maybe on a Friday night or Saturday night, and maybe have 2 glasses of wine.
Yeah. Do you drive as well?
No, I don't drive.
Okay. Have you had any recent travel at all?
No.
Okay. Do you have any ideas what you think might be going on? Like,
No, I really don't know at all what it might be.
do you mind if I listen to your heart sounds, listen to your chest, do your blood pressure, check your lower legs, if that's okay?
Yeah, okay.
Perfect, thank you. So what was the diagnosis in this case? He has chest pain radiating to his neck, brought on by exertion. The pain lasts approximately for 1 minute and is relieved when he rests. He has hypertension and high cholesterol, and he is an ex-smoker. This patient has stable angina because it is predictable in onset, reproducible, and relieved by rest. When taking a chest pain history, there are 3 main questions you need to ask yourself. Number 1, can we characterize the symptoms? Number 2, what is this person's risk of cardiovascular disease? And number 3, is this an acute presentation that requires admission now? Angina is chest pain or discomfort caused by an insufficient blood supply to the myocardium, and it's most often caused by obstructive coronary artery disease. However, there are other abnormalities which can cause angina. Do you know what they are? Choose from the following. What do you think? I'll go through the answers towards the end. You can diagnose typical angina if a patient has all 3 of the following features. Number 1, constricting discomfort in the front of the chest, neck, shoulders, jaw or arms. Number 2, it's precipitated by physical exertion. And number 3, it's relieved by rest or GTN within 5 minutes. Atypical angina is when 2 of the above features are met, and if only 1 is met, you can diagnose non-cardiac chest pain. Of course, please bear in mind that in real life, patients don't often say they have constricting chest pain radiating to the jaw and left arm, brought on by physical exertion and relieved by rest. It's a lot more muddier, and quite often the presentations can be atypical. However, we know that stable angina is unlikely if the pain is prolonged, unrelated to activity or associated with dizziness, palpitations, difficulty swallowing or tingling. What you really need to gather in your history is this a stable presentation or an unstable presentation? The latter requiring hospital admission. We definitely need to rule out an impending MI because we know that time is muscle. So in addition to asking about all the red flags, ask them, why present now? Has anything changed? How often is it happening? How strenuous or how light is the activity before the pain starts? That's so important because if he's saying it's on minimal exertion, such as walking from the bedroom to the toilet, then alarm bells should be ringing. Ask, is this a chronic presentation that has suddenly worsened, or have you had any episodes that have occurred at rest? So, with the patient in front of you, assess their cardiovascular risk factors. Now, this includes the patient's age, being of male sex, smoking, hypertension, diabetes, high cholesterol, obesity, having previous cardiovascular disease, have they had a previous MI, or do they have a stent? Do they have a first-degree relative with a premature history of coronary artery disease? Specifically, a first-degree male relative less than 55 years old, or a first-degree female relative less than 65 years old. Anything above that is not classified as premature cardiovascular disease. Do they have a condition that causes chronic inflammation, like rheumatoid arthritis, CKD, SLE? The reason why chronic inflammation is a risk factor is that we now know that atherosclerosis is actually an inflammatory process. It's not just fatty buildup in the vessels. With angina, the examination may be unremarkable, but it's so important that you do a thorough examination to pick up any murmurs, any heaves, and of course to know the patient's blood pressure. So going back to my original question regarding the causes of angina, apart from coronary artery disease, what else can cause angina? Take a moment to think about the underlying mechanism of angina. The heart is not getting enough blood for what it requires, and this can be due to a mismatch as opposed to an obstruction in the coronary artery. What I mean by mismatch is that the muscle demand outweighs the blood supply, so angina can occur in conditions such as hypertrophic cardiomyopathy, hypertension, and aortic stenosis. All of these conditions will increase the amount of LV mass, but the blood supply might not have had time to catch up. And so when patients exert themselves, they can get these typical angina symptoms. The thing about these subset of patients is that they might not have the traditional risk factors that we think about when it comes to coronary artery disease. Also, anything that reduces the oxygen supply can cause angina symptoms such as blood loss or anemia. Other causes of angina include vasospasm, which is when the arteries constrict inappropriately, similar to Raynaud's. So in answer to the original question, the answer is all of the following can cause angina. So what would be your management plan in this case? As this is stable angina, refer to Rapid Access Chest Pain Clinic for confirmation of the diagnosis and to assess the severity. I'd do blood, do FBCs, U&Es, TFTs, LFTs, HbA1c, cholesterol, and I'd do a 12-lead ECG. So what are you looking for in an ECG? You're looking for ST elevation, ST depression, left bundle branch block, T-wave inversion, Q waves. Also, it helps to exclude other causes such as atrial fibrillation, pericarditis, and left ventricular hypertrophy. But remember that a normal ECG does not rule out angina. It's also very good to compare to a previous ECG if you are lucky enough to have that. Talking about this case I have just shown you, let's say I did an ECG and it was normal. I'd then go on to prescribe a GTN spray. With this new prescription, I always safety net on its usage. So this includes calling an ambulance if the pain doesn't settle within 5 minutes of using it, and warning the patient about the side effects that can make them feel really lightheaded. So sit down or lie down when taking it. Lots of patients with stable angina present to A&E because they have taken their GTN standing and felt faint. The treatment for angina is mainly to prevent a cardiovascular event from occurring. So this involves mainly risk factor modification. Can this patient stop smoking? Can they lose weight and increase their activity levels? Can they start a cardioprotective diet? You should consider a statin, and aspirin may be commenced depending on the individual. There are lots of other drugs, but I'm not going to delve into that into this tutorial. Before we end this tutorial, I just want to emphasize something. If all you have is a hammer, everything looks like a nail. So challenge your cognitive biases and think, what else could be causing this chest pain? I like to divide the causes into two: life-threatening and non-life-threatening. You might feel a bit overwhelmed with all the possible diagnoses, but you just need to see as many patients as possible with chest pain in order to get good at it. There are no shortcuts to experience. Experienced clinicians use a non-transparent reasoning process which involves recognizing patterns and combinations of findings. We do this on a subconscious level too, and this skill improves with seeing lots of patients. It's hard to describe this process, but it's almost like recognizing someone's face. Sometimes this process is referred to as Gestalt, which is German for overall impression. Let me know in the comments if you'd like me to make another video on other causes of chest pain. Stay tuned for our exploration of hemoptysis and exertional dyspnea to be released soon. Thank you for watching, and I'll see you in the next video.